Thanks, Christine. And Harky, great presentation. I want to apologize. I'm a little sick, so if I sound a little funky, heads up in advance. So the title of my talk is Redefining Success Measures Beyond the Western Glass Ceiling. I wanted to take a different approach to my talk. I feel like a lot of times during these seminars, we speak about everyone's amazing research programs, rightfully so. But for myself, being an ECR over the past couple of years, I wanted to focus on what didn't go so well, what I anticipated to be going in a certain direction and didn't, and how like the art of the pivot has strengthened allegedly me as a researcher. So without further ado, my name is Sahr Wali. I'm an assistant professor at IHPME at the University of Toronto, which is my academic institution, and I'm also a scientific associate at the Ted Rogers Center for Heart Research based at UHN. So my academic journey, much like many others, I started with doing my undergrad at York in biomedical sciences, and I did a minor in theater, which I loved. I actually tried to bring that sense of theater and arts into my work now, and I think it's really allowed my research portfolio to be a bit more diverse. I transitioned into doing my master's at Mac in eHealth, where I wanted to focus on understanding engineering and the intersections with health sciences. And during the COVID era, I got to do my PhD in health services research, where I had a fantastic committee supervised by Dr. Joseph Cavazzo and Dr. Heather Ross. Now that sounds all fancy. It makes me sound like some fancy pants person, but in reality, this is really me. I am a middle child of five kids from two parents, two immigrant parents, originally from Afghanistan, who had the privilege of raising a family on the lands part of Treaty 13, which is where I'm joining you from today. And when I think about my academic career and really the title of my talk of, battling this Western ceiling, I wanted to go back to my roots, why things were important to me, how there's certain days where you get out of bed and you question why you're doing certain things. Do you have the motivation? And for me, what I'm really trying to grasp is maintaining a level of authenticity, not just from the academic standpoint, but by bridging all of these components together as a whole. And I find that we all work long hours, but I have a smile on my face most days as I'm bringing this sense of self back into my research. So with that, I thought I would start off with the agenda. I have some hot takes, so but put your seatbelts on. I wanted to really take a second look at the core competencies and then question ourselves on how do you measure competency and how do you reassess success beyond the norm? And my one take-home message as we go through would be, we really need to get comfortable being uncomfortable. And I think that's where meaningful change starts. So to give you guys a quick overview of my research program, so as part of my ECR, the title of my program of research was Bridging Our Worldviews, Using Reflexive Innovation Strategies to Transform Culturally Safe Care in Underserved Communities in Ontario. The goal of my research program was really to build on the strengths of existing resources and sources of knowledges to support the equitable provisions of cardiac health services, specifically in First Nations communities in the remote James Bay region, as well as Black communities in the Toronto area. And to do this, I had three objectives. One was to look at how clinic and community relationships really define the challenges, the barriers, and opportunities for culturally safe care. And then the overarching goal was really to create this integrated care pathway where there would be these linkages to clinic and community resources with this big goal for holistic health services. And the overarching piece for sustainability was to have this health equity network to foster co-learning across both community and healthcare institutions. Sounds great so far, allegedly. So now we fast forward into the enriched core competencies for health systems and policy research. This is a beautiful figure. It encapsulates so many different components that are really key to health research, talking about partnership engagement, project management, and then having this overarching piece of EDIA and Indigenous cultural safety. But I'm going to be completely honest, whenever I look at this figure, I ask myself, what does this mean for me? How do I maintain a level of authenticity that I'm addressing each piece, but not in a tokenistic way? And that every piece or component or question that's proposed is not being proposed to kind of tick off that I'm looking at each aspect, but it's being done in a way that actually serves the goals the community has dictated. So with that, when we started my ECR journey, we had this activity where we had to think about, what core competencies are we going to be addressing? What are our professional development? And I landed that, hey, I'm building these existing and new linkages. So I'm doing collaboration, interdisciplinary work, and networking, and I want to create this pathway with Western medicine and community knowledge. So I'm going to be talking about dialogue, negotiation, analysis, critical thinking. And I have this large goal for a health equity network to bring academics, community members, and trainees together and potentially creating a course. Because for myself, I come from a digital health background. So I wanted to look at traditional and non-traditional methods for digital tool design. So I asked myself, and like as the kids are saying, like, am I cooking? Like, is this all fine and dandy? Like, am I on the right path? And the reality was, things don't go as planned. I had all of these ideas proposed, and despite, for myself transitioning from my PhD to an academic position, the partnerships that I had with the James and Hudson Bay communities, the Moose Cree First Nation, these were relationships that I was able to, foster over the past 4 to 5 years. But even then, I just felt that things weren't sitting right and that the ideas and the projects that were proposed when I had submitted this proposal, they weren't a priority at that time. And even with the Black communities, with Black Health Alliance that I originally had formed this partnership with, I had to take the reality check that even though something was important in that moment, it doesn't mean that it continues to be important at the present moment. So with this, I found for myself to keep myself in check this holistic cardiac care pathway in the James and Hudson Bay region. We originally wanted to merge the program that the UHN cardiac team has been supporting through a program called Medley and create these linkages for First Nation support. But I was told, by our elders that how are you creating a linkage or a bridge with a program that doesn't exist? We wanted to create something that was Indigenous led, based in traditional teachings for heart health. And you're saying to propose a connection to Medley. What are we connecting to? You're talking about integrated care, but you're really just proposing the same Western mindset of wellness and you're slapping some key terms in there to make ourselves feel good. And then on the other end, I had a great relationship speaking to folks from Black Health Alliance, and they told me that right now our teams are overburdened. We don't have the capacity to have a referral network, and we definitely want to do it, but there's not any time or space to do it at this time. And who's going to be responsible to be that supportive personnel? And is it going to be still relevant next year? Because right now we're dealing with a big priority here regarding mental health. So for me, in the first year of my ECR and all of this pressure, I really was spiraling. And I didn't know what to do in that pace. And I really felt that I had all of this training with and mentorship from my academic supervisor, Dr. Angela Mashford Pringle, who's asking, how do you want to keep yourself accountable for priorities that the community is dictating? And as these priorities are changing, what would make you happy? And I go back to this figure on the level of community engagement. And there's so many good examples of having workshops done, having partnerships. But I really sat with this figure and asked myself, what is the purpose of this work if I want to go and be one-to-one with what I proposed on paper compared to modifying my approach and really taking a back seat and starting fresh and being happy with the work that I was doing? So I go back to this question of, whose research is it? Who's defining the goals? Do the right people have a seat at the table? What's the success look like? And according to whose definition? And, for myself, coming from an immigrant family, I always felt that when I would go to the doctor with my parents who speak fluent English and have been here for over 35 years, they always felt they weren't being seen. And in this moment that, all of my projects were being flipped upside down, I felt like I was not being authentic to, the 13-year-old version of Sahar who was accompanying her parents to appointments. Why is it that I'm only looking at one piece of a community relationship or a community priority when I've experienced how that feels to not be fully seen in that full picture? And you start to question yourself, who benefits? So as I, fast forward and I love this ideology of your truth is not my truth. I really started to do some, reflexive exercises on my own because a lot of times when we're doing health equity based work or community based work, the onus is on the community to tell us, what is priority for them, but that's not always fair. And I think as a researcher and an academic, you forget that you have to do your homework too, and you have to come with ideas and propositions that 99% will get shot down, and that's okay. And for myself, I found it was really good value and a really good exercise for me to evaluate competency from these different levels and these different perspectives. So you ask yourself, what does success look like? And I came back to this principles of two-eyed seeing, which is really a really nice way of looking at the world with one eye grounded in indigenous worldviews and another eye in Western worldviews. And when I say indigenous worldviews, everybody's indigenous to somewhere. And these perspectives really bring a strength-based lens to wellness, looking at relationships, interconnectedness, looking at people as partners instead of participants. And I use this methodology throughout the course of, my research and my PhD and now, but I wanted to do like a hot take and try to flip it in and bring in the enriched core competencies and think about how do we take these core competencies and flip the narrative and have two perspectives over the same component. And it's a difficult task because there's so many intertwined pieces that can be interconnected. But I think for myself, it allowed me to be more accountable in questioning each step of my research program as a whole, as partners with the various groups that I was working with. And so now we go back to one of the projects with the James and Hudson Bay region when I asked myself, why am I doing this? And the exercise that I started to think through is during the entirety of our sharing circles, our community-based works, the key thing that we came up with community members was heart health is more than just metrics. And there's this really big need for community-led supports to be grounded in First Nation teachings. That's why we're doing this work. It's not to create integrated care program. It's not to slap all these institutions together and pat ourselves on the back and say we're doing a great job. It's really that there's this gap, and this is what community has vocalized as a priority. Now, what does success look like and according to whose definition? Success means creating a safe space for community members to share their experiences in a way that honors their trauma, but also their resilience. So, what I mean by this is so many times within Western medicine, we look at illness, we look at symptom burden, deterioration, but within Indigenous health, they look at a more holistic perspective in terms of wellness, getting back to self, getting back to whole. And as we think about how do we bring all of these ideas together, this sounds all great in theory. What we did as a team, and when I say we, it's really, I'm so grateful for Elder Norm Wesley, who has really been championing this work with me, is we shifted the entirety of how this program of work would begin and started to think about, where do community members feel the most safe? And what we learned is across the region, there are a number of land-based programs that have done fantastic work in detox, in women's health, and youth leadership. And the gap that we found was there is nothing for heart health and wellness within a land-based context. So instead of looking at things from the notion of integrated care, we wanted to focus on learning from the strength of existing land-based programs and then figure out how can we potentially create something for heart health. So to do this, what does success look like? We hosted a number of community gatherings, bringing hunters, fishermen, clinicians, staff, anyone who is really interested in leading or participating in this work to really just share a meal, talk about their frustrations, and then also come up with a few ideas on, what should something like this look like. And even though, as I mentioned, I'm based in a digital health context, doesn't mean that we're not going to be proposing anything digital, but it just means that that's not going to be our starting point. It's always going to be on the table, but it's up to the community to decide what they would want to do with it. And, one of the biggest chunks of our budget actually shifted from, hiring graduate students to actually building a Shabatuan, which is a cook tent at a land-based camp, because that was a source of community. That was a source of wellness. And that was also a form of reciprocity that we're not just trying to do a project and leave, but this would be something that the community would be able to continue to use, not just for the heart health program, but also for any of the other programs at the land-based camp. Now, shifting gears, thinking about Black communities in Toronto area, the reason why we started doing this work and the reason why I wanted to really partake in working with other people of color is I saw myself in this role of seeing families come up within different programs, and it's usually your white high income families that are participating in digital or clinical programs, and I didn't see people like myself, and that's starting to change, but the reality is in both research and in care, people of color report the highest risk factors for cardiac deterioration, but they're the least involved. And it doesn't mean that they don't want to be involved, but there is that white coat syndrome. There is that fear that continues to be present. And I look at my parents who, are in their 60s now, and they still want me to attend with them. And that just goes that it's not that they're doing something wrong, but it's the system that has failed to make an inclusive environment. So when we think about, what does success look like, and according to whose definition, I started to shift from Black Health Alliance to actually working with Pathways to Education, which is a youth education group. And we found that, youth caregivers play a really big role in health system navigation. I played that role. I never even thought to think about myself. And for us to look at success in this context, we thought, let's take a pause on integrated care. And let's think about how do we develop a youth health system leadership program for community access centers to streamline trusted care supports. So it's someone that's already embedded in the community, who has these relationships present, and who wants and has the time to actually support those who are in need. So with this, we modified our approach to actually partner with high school mentorship programs in Regent Park and Scarborough to learn from the strengths of existing programs and the gaps that are currently present. And I kid you not, I am so proud of these high school students. They're so tremendously smart and intelligent and creative. They support, their families, their neighbors, by providing bilingual supports, accompanying folks to different cardiac or clinic visits and so forth. But to get there, to figure out how do we, bring all these people together instead of having, community fees, we actually worked with the high schools to have open houses, to have mentorship workshops, and I invite both parents and children to come and figure out what role they wanted to play. A lot of the times in low-income neighborhoods, it's not that people are not educated, but it's that their education or status of education is not recognized in Canada. They may be doctors, engineers within different contexts, but those skill sets are underutilized. So how do we leverage that skill set and empower people to become champions in their own communities? And similarly, when we're thinking about digital innovation, we didn't want to think of it from like a program management or implementation, but we wanted to think of it, how do we use things like AI as capacity building in education? How do we create modules so this type of support exists forever and not just as a pilot project? So with this, my overarching takeaway is the community goals are still to move towards integrative care, but the way we got there, it looked very different. I had originally proposed doing interviews, doing workshops, and so forth. Still, the essence of those methods are present, but the way that each was implemented, it aligned with what was priority for the community at that time and what bandwidth that they had at that time, instead of myself proposing something that was written on paper that was no longer relevant in today's context. So with this, when we think of success measures beyond the academic norm, we think about, accepting that rejection isn't personal. It's a form of collaboration. Sometimes it's not no, it's just not now. And, embracing the art of the pivot to create linkages that did not exist. Those are forms of project management and communication, because consistency without an agenda is really key to authentic relationships. And building capacity in community for community, that's mentorship, that's knowledge mobilization. Because at the end of the day, talk is cheap, and you can't meet people where they're at if they're not even there. So as I, wrap up, to think about, what success is to me, it's staying authentic to the roots of my values. I was up in Moose Factory, a couple of weeks ago. It was minus 40. I got frostbite all of my face, but I loved every moment of it. I loved, going back into community and seeing people who shared similar experiences or connected in different ways of different cultures. And I love going up. I love working with the high school students and seeing versions of myself and being able to champion things that I didn't have a platform to, and really getting comfortable starting uncomfortable conversations. We are all based in really large academic institutions, and to have meaningful change, sometimes you have to put your foot down. And I've had many doors closed on me and many people not understand why I want to proceed in a certain way, and that's okay, because if someone is not willing to hear you out, then it's just not their time, and that's really a tough pill that you have to swallow. And, you got to slow down to go fast, and innovation can be defined in many ways. And that's something that's really difficult in digital health space. But I think for myself, I've really, gotten more comfortable with being in this type of position. So thank you guys for listening to me. I hope you enjoyed my therapy session and there was some tidbits we can all learn from.